Assalamualaikum and a very good day to everyone. My name is Dr. Mardiana and I will be delivering the lecture on diseases of the male genitalia. I will be dividing the lecture into two parts. So let us go through the learning objectives for the lecture. At the end of this lecture, you will be expected to be able to describe the risk factors, the pathogenesis, morphology, and clinical effects and complications of these entities, which are hyperplasia of the prostate, carcinoma of the prostate, testicular neoplasms, and carcinoma of the penis. Skills-wise, you will be able to identify the morphology of prostate hyperplasia and carcinoma, and also testicular neoplasms. The lecture is divided into two parts, and for the first part, we will focus on benign prostatic hyperplasia and prostatic adenocarcinoma, with corresponding learning objectives focusing on these two entities only. A brief review of the anatomy of the prostate will show you that the prostate can be divided into several anatomically distinct zones, as you can see labeled here as central zone, transitional zone, and also peripheral zones. What is relevant to our topic today is that central part of the prostate is often involved by prostatic hyperplasia, while carcinoma is more often arising in the peripheral zones of the prostate. Another thing to take note is that the location of the prostate itself that sits at the apex of the bladder, and you can see the urethra passing through the prostate, forming the prostatic part of the urethra. You can see seminal vesicles here at the posterior aspect, as well as its close proximity to pelvic wall and also the rectum. So as you probably know, that digital rectal examination is one of the examination methods to assess the prostate, and this is explained by its close proximity. So also important is that in conditions such as carcinoma, direct spread of cancer can involve these neighboring organs and structures. Okay, so these are the two entities we will discuss today, hyperplasia and malignancy. So start with BPH, short for benign prostatic hyperplasia, occasionally also called nodular hyperplasia. This is very common, okay, and its incidence increases with age. Hyperplasia, as you know, means increase in the number of cells, and in the setting of BPH, the hyperplasia involves both the epithelial cells as well as the stromal components. An important point to note is that the process almost always involves the central part of the prostate or the periurethral zone. In terms of pathogenesis of BPH, there are a few key points worth mentioning. Okay, number one, it is an androgen-dependent process, i.e. androgen is required for the prostatic growth seen in BPH. And in the process of formation of BPH, DHT, which is short for dihydrotestosterone, is the ultimate mediator of prostatic growth. So where does DHT come from? Testosterone, actually circulating testosterone, is converted to DHT by the action of 5-alpha reductase type 2 enzyme. Okay, so once you get DHT, then the DHT binds to androgen receptor in the prostatic stromal and epithelial cells, and the binding of this DHT to androgen receptor will stimulate the transcription of androgen-dependent genes to promote growth and also cell survival. So just let's look at that in terms of image-wise. So again, just to recap, you have circulating testosterone, okay, which enters the stromal cell, and they get converted into DHT by the action of 5-alpha reductase type 2. Okay, then the DHT will bind to the androgen receptors in the stromal cells as well as in the epithelial cells. Testosterone can also bind to androgen receptors. However, DHT is way more potent, so therefore they form a much stable complex compared to testosterone and androgen receptors. So what's the outcome of that is you get transcription of androgen-dependent genes, and subsequently you get proliferation of stromal cells and decrease in epithelial cell death, with a net effect of an increase in the number of epithelial and stromal component. Okay, so this is a cut section of a prostate showing typical gross morphology of BPH. As you can imagine, with an increase in the number of cells present within the gland, then you expect the gland to be massively enlarged. And that's exactly what happens in BPH. Okay, so this is a massively enlarged prostatic gland. And just to show that, orientate you, this is the prostatic urethra. Okay, so this is the periurethral zone. This is the posterior aspect of the prostate, and this is the anterior aspect of the prostate. Okay, so the weight of a normal prostate is around 20 grams. So in BPH, this can be increased significantly to around 60 to 100 grams. Okay, the process is periurethral in location. They often form nodules, okay, of varying sizes, but they can be quite circumscribed. In addition to that, you can also see some cyst formation. But what is important to note is that because all these processes are periurethral, they tend to compress on the urethra. So you can see the urethra is now just a slit-like space, and that can impinge on the urinary flow, and that would explain a lot of the urinary symptoms that these patients may present with. Okay, so the histology of BPH, again, it mirrors the gross findings. You can have nodules as outlined here, and you can have increase in the number of cells or also stromal components. And here there is quite a marked increase in the number of cells, which are actually highlighted by the fact that now we have these papillary infoldings of the epithelium into the lumen, and this is because there's just too many cells to line the glands, and they've got nowhere to go, and they start to project within the lumen. But more importantly, what I want to show is the fact that we have two layers of epithelium. Okay, so one, which is the part on the inner side projecting to the lumen, and that's the columnar epithelium. And also we have another layer of flattened basal epithelium underneath that. So this two-layered epithelium is characteristic of benign prostate, and it's an important distinction from prostate cancer, because in cancer you will lose the basal epithelial layer. The clinical manifestations of BPH stems from the fact that the disease is centrally located within the prostate. So this results in impingement of the prostatic urethra, causing bladder outlet obstruction. So patients tend to present with a set of symptoms which are quite typical of BPH, which are termed lower urinary tract symptoms. So the lower urinary tract symptoms can be divided into two sets, which are the voiding symptoms, okay, as shown here, as well as the storage symptoms. So let's start with the voiding symptoms. Voiding symptoms simply imply that the patients have difficulty passing urine in a normal manner. The pathophysiology for this set of symptoms is actually quite simple. So if you look here, BPH affects the periurethral zone of the prostate. Therefore, it leads to compression of the prostatic urethra and obstruction to urinary flow. So this gives rise to hesitancy and poor stream. In order to overcome the obstruction, okay, the patient may need to even strain to urinate. So that explains the voiding symptoms that these patients may have. The pathophysiology for the storage symptoms is a little bit more elaborate. However, they too begin from the bladder outlet obstruction. So because of the obstruction, as you can see here, there is now increased resistance for urinary flow from the bladder. This obstruction produces two outcomes. Number one, there will be increased work for the detrusor muscle, okay, to help urine to be emptied from the bladder. So the detrusor muscle will hypertrophy and becomes thickened. So the thickened wall of the bladder is now unable to stretch properly, and that will lead to impaired storage of urine. Therefore, that produces the symptoms of frequency as well as nocturia. Secondly, the bladder outlet obstruction also results in increased sensitivity of the detrusor muscle to stimulus. So what happens is that the bladder may contract suddenly even though there is not much urine present within the bladder. So this leads to urgency and incontinence. So as you know, in normal situation, if you have only a small amount of urine, you won't really have the sensation to micturate. But this is not the case for benign prostatic hyperplasia. Okay, so we have discussed voiding symptoms and storage symptoms. Now we're into the complications of BPH. The first one is urinary tract infection. Okay, so how does that come about? Again, bladder outlet obstruction results in incomplete emptying of urine from bladder, so that will leave some residual urine within the bladder, and this urinary stasis will favor infection. So the patient may get urinary tract infection, which is otherwise quite uncommon in males. There are several other complications that can arise in the setting of BPH. Okay, number one, they are in the form of structural changes within the urinary tract, namely the bladder, the ureters, as well as the kidneys. Okay, so what does that mean? So let's just go through that. So first, with the bladder outlet obstruction, this will increase work of the bladder, as we mentioned earlier. So the bladder hypertrophies, and in addition to that, the obstruction also leads to increase in intravesical pressure. So the bladder thickens, they can become, or they can have trabeculation, they can form diverticula, but eventually the bladder will dilate. And the dilatation of the bladder, in combination with the increase in intravesical pressure, will allow reflux of urine to go up proximally. And this will lead to structural changes and dilatation within the ureter, named hydroureter, and also of the renal calyces, named hydronephrosis. The second complication is ascending infection from urinary tract, a lower urinary tract infection. So now that the urine refluxes up fairly freely and easily, whenever there is a lower urinary tract infection, this can ascend up to involve the upper urinary tract and produce pyelonephritis. And pyelonephritis, as you know, can be complicated by septicemia. So what else can pyelonephritis do? If it destroys enough functioning nephrons, then it can present with renal failure. In addition, when they resolve, they also resolve by scarring, and that can also lead to renal failure. In addition to that, a few points we have mentioned earlier: the presence of urinary stasis and also recurrent urinary tract infection. These are conditions that favor renal calculi formation, so patients may also be complicated by the presence of urinary stones either within the bladder or within the kidney. And lastly, patients may also have urinary retention, which may be acute or chronic. Okay, acute retention may be precipitated by sudden enlargement of the prostate, for example, due to infarction or local inflammation, and they call for attention because of its sudden presentation. Patients can be quite distressed because they are unable to pass any urine at all, but chronic urinary retention develops gradually, so they may not be as dramatic as an acute urinary retention. Okay, just briefly on investigations and management. I'm not going to say much about this, but usually a careful history and examination will be sufficient for the diagnosis of BPH to be rendered. Occasional other investigations can either help in equivocal cases or to exclude complications as well as to exclude prostatic carcinoma. So, for example, one thing worth mentioning is the serum PSA, prostate-specific antigen, which can be mildly elevated in BPH, but usually not to the extent that you see in prostatic carcinoma. So that can be helpful in the distinction. And occasionally also you can do imaging, such as ultrasound, you can do cystoscopy, and you may even need to biopsy the prostate in cases of which you are uncertain of. And there are several management aspects which I will not go into. Okay, we will now discuss prostate adenocarcinoma, which is the common malignancy arising within the prostate. Okay, before we go into a more serious matter, let's just have a quick quiz to see how good you are with your celebrities. Okay, so which of these famous actors successfully battled prostate cancer? Is it Ben Stiller, your Iron Man, Ian McKellen, or better known as Magneto, or Tom Cruise? Believe it or not, these two lads, Ben Stiller and Sir Ian McKellen, both had prostate cancer, but they are now in remission. Okay, so quick quiz done. Serious matters, adenocarcinoma of the prostate. It is the most common form of cancer in men, typically increasing in age. There are national and racial differences in the incidence of the disease. So luckily, in a way, the disease is actually quite uncommon in Asians, and they occur most frequently among blacks or Africans. There are some environmental factors which are postulated to be involved in this. For example, immigration, diet, because it has been said that westernized diet among Asians have also resulted in some increase in its incidence. But more importantly is again to highlight the location of the disease, which is often in the peripheral zone of the prostate rather than centrally, as we have discussed in BPH. The pathogenesis of prostatic carcinoma is not as well defined compared to BPH. However, there are some factors that play a role in its pathogenesis. So number one, it is also an androgen-driven growth, similar to BPH. However, the androgen, even though it's required for the survival of the prostate cancer cells, its role as an initiator of carcinogenesis is not yet proven. The second important factor is family history of prostate carcinoma. So this is part of the hereditary factors in its carcinogenesis, with an increased risk of cancer if there had been a first-degree relative diagnosed with it. The third factor is environment. So the environment, including diet, may also play a role. And lastly, acquired genetic aberrations. Specifically, for example, the TMPRSS2 ETS fusion genes, which is the most common genetic aberration seen in prostate cancer. In terms of morphology of prostate carcinoma, it can be quite difficult to see grossly, but often the tumor is located towards the peripheral zone. So in this particular image, you can see that the tumor has an ill-defined borders and has a cream or tan cut face. Okay. Note that the general shape and the structure of the prostate and the prostatic urethra, okay, which is in the central part here, is generally preserved when compared to BPH. So patients may not have similar prostatic enlargement, and because of the peripheral location, patients may not have the urinary symptoms as you expect in BPH. So here's another image of prostatic adenocarcinoma, a gross morphology of it. So again, the prostate is actually relatively small or preserved in terms of size, and here you have multiple tumor foci, okay, as highlighted by the circles. Again, they are peripherally located, they are often posteriorly, and they often also form multiple ill-defined foci of tumor. So they may not be enlargement, as we have discussed. Okay, so moving on to the microscopic morphology. Just to highlight here that again, because it is an adenocarcinoma, so what do you expect to see? You expect to see malignant or atypical glands. In prostatic adenocarcinoma, the glands are typically small and crowded. So crowded in the sense that they are very close to one another. Okay, let me just show you using the pointer here. So you can see that there's hardly any stroma in between, so they're very crowded. They are small, but the cells are large, and if you look at high power, you will start to see prominent nucleoli. And also in some of these glands, you can see intraluminal mucin. Okay, so that's the bluish material within the lumen. As I mentioned earlier, in BPH, you have two layers of epithelium, the inner columnar as well as the basal epithelium. So in prostatic adenocarcinoma, the main distinction that you can see microscopically is that in cancer, there will be loss of basal layer. So this is a special stain that we use in the lab, and the basal layer or the basal epithelium will be highlighted brown, whereas the malignant columnar epithelium will be highlighted as red. So you can see that these are the malignant glands, it's highlighted red, but there is no more brown color. So that indicates loss of basal epithelium. So this single layer epithelium is diagnostic of carcinoma. Next, we will discuss briefly on the behavior and spread of prostatic carcinoma. So again, recall the anatomical location of the prostate. The prostate cancer can spread directly to adjacent structures and organs, such as the seminal vesicles, the base of the bladder, and the pelvic wall. Prostate cancer can also spread or metastasize via the lymphatics channels, and that goes to various lymph nodes, especially the sacral, the iliac, and the para-aortic lymph nodes. And if they enter the bloodstream and they cause hematogenous spread, they tend to go to the bone, causing osteoblastic metastatic lesions in the lumbosacral spine, proximal femur, pelvis, for example, but also to distant organs such as lungs and liver. So here in the vertebra, you can see multiple metastatic nodules of varying sizes are present here. So clinical features of prostatic carcinoma can be quite varied. Okay, so a number of patients can be asymptomatic, or the disease may be silent, especially if the tumor is small and peripherally located. If the tumor is locally advanced, let's say if it involves the base of the bladder, then or if it is locally advanced and it starts to involve the central part of the prostate and impinges on the prostatic urethra, then the patients can present with urinary symptoms. The third way how patients can present is really with features related to bony metastases. Okay, so for example, metastatic tumor to the bone can produce bone pain. If it's involving the vertebra at the back, then you can get back pain. Patients may have pathological fracture because of the weakened site of bone due to the metastatic focus. If there is bone marrow involvement, patients can present with features of marrow failure, such as anemia. Okay, so although this is quite uncommon. Lastly, metastases to lymph nodes can produce peripheral lymphadenopathy, which may be the first presenting point. Briefly on examination and investigation, so digital rectal examination is one of the methods, as we mentioned earlier. Serum PSA is useful because PSA tends to be markedly elevated in prostatic adenocarcinoma. Often the diagnosis will require histological examination in which the tissue is obtained via transrectal ultrasound examination. And the management is beyond today's topic. Okay, so that's the end of prostatic adenocarcinoma, and I just would like to go through a quick recap of what we have covered in part 1 of the lecture. So we covered BPH and prostate adenocarcinoma. The incidence is comparable, but the location is different, one being periurethral in location and the other is much more peripherally located. Both are androgen-dependent process, however, there is a distinct role of DHT in BPH, but the pathogenesis of prostate adenocarcinoma is a little bit more obscure. The clinical manifestations and complications are also quite distinct in that BPH tends to produce urinary symptoms, and these relate directly to the severity of the obstruction of the urethra. Whereas in prostate adenocarcinoma, urinary symptoms are uncommon and the presentation relates more towards local or distant spread of cancer. The gross morphology also differ, as we've shown earlier, and microscopically the main distinctive feature would be the fact that BPH is lined by two-layered epithelium, but in prostate adenocarcinoma there will be loss of basal epithelium, leading to presence of infiltrative malignant glands lined by one layer of epithelium only. So that's the end of part 1. The references that I used are listed here. We will see you shortly in part 2.